Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will talk about one of the most important topics in cardiology, which is called acute coronary syndromes. Firstly, we have to talk about atherosclerosis in general, which include all the vessels and all the arterial tree, including coronary, cerebral, renal, and peripheral vascular system. Atherosclerosis means stiffness and thickening of the arterial wall. And atherosclerosis in any artery have the same pathogenesis, which we'll discuss later. Atherosclerosis process firstly starts with intimal injury, as we see here. This is the arterial lumen and this is the arterial wall, consisting from intima, media, and adventitia. The intima is lined by endothelial cells. Atherosclerosis starts by endothelial or intimal injury, and then both LDL, low density lipoprotein cholesterol, and monocytes, one of the inflammatory cells, enter and invade the intima. And then the monocyte take the cholesterol and turn into macrophage, which is now LDL-laden monocyte, the macrophage, and then accumulation of more lipids turning into foam cells. And now we have what's called vulnerable plaque, consisting of inflammatory cells and LDL and the macrophage. And at any time, this atherosclerotic plaque can rupture into the arterial lumen, causing thrombosis. Regarding the risk factors of atherosclerosis, we have modifiable and non-modifiable risk factors. Modifiable risk factors as hypertension, diabetes, dyslipidemia and obesity, smoking, chronic kidney disease, sedentary life without exercise, and type A personality, which are the stressful persons. And non-modifiable risk factors like elderly, the age, the male sex, and the family history of premature coronary artery disease, males less than 55 and females less than 65 years old. Coronary artery disease or ischemic heart disease, in most cases we have two types, atherosclerotic and the non-atherosclerotic coronary artery disease. In most of the cases, it is atherosclerotic coronary artery disease resulting from atherosclerosis, as we discussed, and it results in narrowing or blockage of the coronary arteries, leading to reduced myocardial blood supply and mismatch between myocardial oxygen supply and demand. Ischemic heart disease until now is the leading cause of death worldwide, and it can be categorized into acute coronary syndrome and stable or chronic coronary syndromes. Our presentation today is about acute coronary syndrome, which means that we have acute myocardial injury due to acute myocardial ischemia or acute obstruction of the coronary flow, partial or complete obstruction, with or without abnormal cardiac biomarkers. Acute coronary syndromes can be categorized according to the ECG and pathophysiology into ST elevation acute coronary syndrome, like ST elevation myocardial infarction, and non-ST elevation acute coronary syndrome, which can be classified into unstable angina if there is no complete obstruction of the blood flow, and non-ST elevation myocardial infarction, which is accompanied by increased myocardial biomarkers due to necrosis. Regarding the pathophysiology of acute coronary syndrome, as we discussed before, it is like the pathophysiology of atherosclerosis in general, starting with superficial erosion of the intima and then plaque rupture into the wall and lumen. we have complete obstruction of the coronary flow, it present with ST elevation myocardial infarction, as we can see in this ECG image. And if we have partial obstruction of the coronary flow, it may be unstable angina or non-STEMI, non-ST elevation myocardial infarction. Unstable angina is mild intermittent impairment of the blood flow and no rise in the biomarkers in the troponin and CKMB because there is no necrosis. Because myocardial infarction equal necrosis. If the patient has unstable angina, still no necrosis, no elevation of the troponin. If the patient has non-ST elevation myocardial infarction, it is associated with rise in the troponin due to myocardial necrosis. And in most of these cases, the patient have repeated episodes of subendocardial ischemia or have occlusion of the blood flow, but the patient have collateral flow which guard against complete obstruction. Because if the patient has complete transmural necrosis, it means ST elevation myocardial infarction. And if the patient has only subendocardial ischemia, it is unstable angina or non-STEMI. So how to diagnose acute coronary syndrome? Firstly, we have to respect those symptoms, especially in the patient with history of coronary artery disease or risk factors of atherosclerosis or coronary artery disease, as we discussed before. The patient frequently has angina, which is chest pain, diffuse chest pain at rest or progressing or lasting longer than before. The patient mostly has discomfort on one or both arms, in the neck and jaw, may be associated with shortness of breath or dizziness, epigastric pain or indigestion, nausea and vomiting or sweating. Physical examination of the patient may be completely normal examination, or maybe the patient have some hypotension, diaphoresis, sweating, transient mitral regurg murmur, pulmonary edema, or chest crepitation, especially if the patient in acute heart failure or extensive myocardial infarction. So what about the investigations? The first thing to be done within 10 minutes of the patient presentation should be ECG. ECG may be completely normal, so we have to respect the chest pain, especially in the risky patients, or may reveal ST elevation in patient with STEMI, or ST depression and T-wave inversion in patient with unstable angina or non-STEMI, or even arrhythmias presenting from the myocardial ischemia like atrial fibrillation, ventricular arrhythmias, or bradyarrhythmia. Second to do is to collect a sample for the cardiac biomarkers, including troponin and CKMB, maybe BNB or CRP in some setting, and collect the lipid profile, because we know if the patient has elevated biomarkers like troponin or CKMB, so there is necrosis or there is infarction, maybe ST elevation or non-ST elevation according to the ECG finding. And if he has negative cardiac troponins, so he has unstable angina if he has typical ischemic chest pain, and we have to collect the blood samples repetitively at 6 and 12 hours to exclude myocardial infarction progressing. About the chest X-ray can reveal findings related to the heart failure like cardiomegaly or increased pulmonary vascular markings with cephalization, and also can exclude other causes of chest pain like pneumothorax, aortic dissection, and pulmonary embolism. Everyone in the emergency department should know well how to diagnose the 4 fatal causes of acute chest pain: myocardial infarction, pulmonary embolism, aortic dissection, and pneumothorax. The role of echocardiography in the acute coronary syndrome: first, to demonstrate if the patient have regional wall motion abnormality, which confirm the diagnosis. Also to calculate the LV systolic function, the ejection fraction, is to exclude the mechanical complications of MI like acute severe mitral regurg due to rupture or dysfunctional papillary muscles, ventricular septal rupture, free wall rupture leading to ventricular aneurysm and pseudoaneurysm, and pericardial effusion with cardiac tamponade. Also, we can exclude other causes of chest pain like aortic dissection, cardiac tamponade, pulmonary embolism, and severe valvular disease. This is a demonstrative algorithm for patients presenting with suspected acute coronary syndrome. We start with aspirin, nitrates, morphia, oxygen if the patient is hypoxic, and perform ECG if there is ST elevation. So this is STEMI. So we have to go for primary PCI or fibrinolysis, thrombolytic therapy, or if the patient have ST depression or T-wave inversion, or even normal ECG. So if the patient have elevated troponin, so this is non-STEMI, and if no elevated troponins, so it is unstable angina. Or if the patient have normal ECG and the chest pain is not typical and repeated cardiac biomarkers are negative, maybe it is non-cardiac chest pain, so we have to confirm to search for another diagnosis. So how to deal with such patients? First, as emergency, we have to exclude the other diagnosis, making triage and risk stratification for the patient according to the history and physical examination, and we have some scores, risk stratification scores, which stratifies the patient into a high risk, should go directly into invasive strategy, or maybe low risk for conservative strategy if the patient is severely hypotensive, cardiogenic shock, have life-threatening arrhythmia, so it is classified into high-risk patient. For all patients, we should start with immediate aspirin, 325 milligram, unless the patient have aspirin allergy, and start intravenous nitroglycerin at 5 to 10 mic to relieve the ischemic pain and give painkiller like morphia. Then we have to give antiplatelet and anticoagulant therapy. Antiplatelet therapy we told as aspirin, starting with 325 milligram, and then long term 75 to 162 milligram long term, and clopidogrel or ticagrelor by loading and maintenance dose, as described for patient STEMI before primary PCI or thrombolysis, or even for the conservative arm. Anticoagulant therapy, we have two classes, antithrombin, which have direct and indirect thrombin inhibitors. We have here the indirect thrombin inhibitors like the unfractionated and low molecular weight heparin. Direct thrombin inhibitors like bivalirudin, it is not routinely used, and antifactor X inhibitors like fondaparinux. Then the radical treatment of patient with myocardial infarction is to give thrombolytic therapy if the patient presenting within 12 hours of chest pain, or if the patient has the facility within 2 hours to go for cath lab prepared hospital to do primary PCI. It is the best treatment for patient with acute STEMI, is to remove the thrombus and restore the blood flow to the myocardium using balloon or stent. If the patient has failed PCR or high risk anatomy, he can go immediately for urgent CABG, coronary artery bypass surgery, which is by opening the chest and taking grafts from the internal mammary or thoracic artery or from the veins of the leg to bypass the occluded segments. Also, surgery has a role in the surgical repair if the patient have mechanical complications of myocardial infarction like ruptured papillary muscle, free wall rupture, or severe mitral regurg. Then hospital treatment should include the long-term treatment of the patient plus aspirin, is to give angiotensin converting enzyme inhibitor ACE within the first 24 hours, which has very important role in the ventricular reversing the ventricular remodeling. Also, the early use of beta blocker has mortality benefit, high intensity statin therapy to reduce the LDL cholesterol, and has also anti-inflammatory effect to prevent the endothelial injury. And then lifestyle modification. We have to advise the patient to stop smoking for weight reduction, to control his blood pressure, blood sugar, and lipids, and dietary counseling. Also, the patient have to improve his exercise pattern to improve his quality of life and functional capacity. Also, we have to continue or other antiplatelet therapy plus the aspirin like clopidogrel or ticagrelor at least for 1 month in the medical arm, or if the patient has bare metal stent for 1 to 3 months, or if the patient has drug-eluting stent for 1 year, and ideally to give 1 year of dual antiplatelet therapy including aspirin or aspirin plus clopidogrel, aspirin plus ticagrelor for 1 year in all patients. This is the best approach. About the prognosis, the outcomes of patients with acute coronary syndrome have 1 month mortality of 1.7% if the patient presents with unstable angina, comparable to 7.4 if the patient have non-STEMI, and 11.1 if the patient have STEMI. And this mortality rate can be greatly reduced if the patient has yearly treatment, especially if he has been